Welcome everyone. This is Dr. Viva, and we were on the series of adults lines and tubes. We were discussing cardiovascular related lines and tubes. Our one session is done. Now two sessions are remaining as far as the cardiovascular lines and tubes are concerned. So we will go to our second session. We'll be discussing few lines and tubes today. Yeah. So today we'll be discussing left ventricular assist devices. So the left ventricular assist device, as the name suggests, it is the use of this device is for mechanical support for patients with severe heart failure. It is also used as a bridge to transplant, destination therapy, or bridge to recovery. It also helps maintaining systemic circulation when left ventricle fails. What is the course of the device? What are the device components that we should be knowing? So there is this inflow cannula and there is this outflow cannula. The inflow cannula projects into the left ventricle just below the mitral valve, and there is this tubing then which is attached to the outflow cannula, and the tip of the outflow cannula should be in the ascending aorta. So we have discussed this. What is the ideal position now? The inflow cannula directed towards the mitral valve, centrally placed within the left ventricular cavity. The outflow graft anastomosis is done with ascending aorta with unobstructed flow. So what are the complications if it gets malposition? So first of all, inflow obstruction. If there is inflow obstruction, then there will be a reduced blood flow, reduced pumping through the assist device. What happens if the inflow part of the device is stuck or it is opposed to the left ventricular wall? Then there will be increased risk of thrombosis or arrhythmia or some damage to the left ventricular wall. If there is kinking or outflow graft kinking, then there will be poor systemic circulation, poor perfusion of the body organs. Can lead to device malfunction, low cardiac output, or embolic complications. So this is how the left ventricular assist device will look like on radiograph. So this is inflow, this is outflow. This part of the tubing is basically made of non-radio opaque material. That is the reason it is not well seen. Now we'll move on to the next, that is impeller device. What is impeller device? Is basically a percutaneous ventricular assist device. It is inserted via femoral or axillary artery. So it provides temporary mechanical circulatory support in cardiogenic shock, also used during high risk percutaneous coronary intervention procedures. What is the course of the catheter? So basically inserted via femoral or axillary artery route. It is advanced further through the aorta, across the aortic valve, and into the left ventricle. So this is how it looks like. Okay. What is the ideal tip position? In the left ventricular cavity, the inlet should be approximately 3 to 5 centimeter below the aortic valve, and the outlet should be in the ascending aorta. What if it is malposition? Then if it is too deep, then there will be arrhythmia, some trauma to the ventricular valve, or some failure of pumping. If it is too proximal, then there will be inadequate flow and reduced support, reduced tissue perfusion. If it is across and impinging the aortic valve, then aortic valve injury can happen. Related thrombosis and hemolysis also might happen. This is how it will look like on the radiograph. The next device we will be studying is CardioVest Total Artificial Heart. So what is CardioVest Total Artificial Heart? So over here, the right ventricle and left ventricle are resected, and these two pumping mechanical devices are used, which is attached to the left ventricle and right ventricle, and subsequently the outflow, it is attached to the aorta and pulmonary artery. Okay. So what is it? It is a mechanical device used to replace both ventricles of the heart, acts as a bridge to heart transplantation in patients with end stage biventricular heart failure. What are the device? What are the parts of device? So the both native ventricles are removed, right ventricle as well as left ventricle. Then artificial ventricles are connected to from right atrium to the artificially connected right ventricle, and from right ventricle to the pulmonary artery. Then left atrium connected to artificially placed left ventricle, which will be connected in turn with aorta. So drive lines exit the body and connect to an external pneumatic driver. What is the ideal position? The prosthetic ventricles lie within the pericardial cavity. Inflow curves well seated in atrial remnants, and outflow conduits properly aligned with pulmonary artery as well as ascending aorta without kinking. What if it is malposition? If there is kinking or obstruction, then there will be reduced cardiac output, subsequently leading to reduced tissue perfusion. If it is malaligned, then there will be increased turbulent flow. There will be increased risk of thrombosis and hemolysis. If there is poor inflow positioning, then there will be inadequate filling that will ultimately lead to reduced tissue perfusion. This is how it will look like on the radiograph. Now coming to Hickman tunnel catheter, we all know this. We have seen radiographs of Hickman tunnel catheter multiple times in our radiology department. So what are the uses of Hickman tunnel catheter? It is basically used to have or secure a long-term venous access. Basically used to deliver chemotherapy agents, parenteral nutrition. Also used in cases where long-term antibiotics infusion is needed, or you need continuous blood sampling. What is the course of catheter? Ideally inserted via interjugular vein or subclavian vein, tunneled subcutaneously over the chest wall, and enter central veins into the superior vena cava. The tip should lie at the junction of SVC and right atrium. What if it is malposition? If it is too high, then there will be increased risk of thrombosis, poor flow. If it is too much deep into the right atrium, then obviously there will be a risk of arrhythmias and risk of perforation, some trauma to the right atrial wall. If it is into the other veins, if the tip goes into other veins such as azygos or contralateral veins, then there will be malfunction, associated thrombosis might happen. If there is extravasation, if there is any injury while inserting, then it will lead to hematoma formation, tissue damage, and poor functioning of the Hickman's tunnel catheter. This is how it will look like. You should be knowing that it should be smooth. The curve portion should be smooth. There should not be any acute kinking over here. If there is acute kinking, then obviously the chances of failure of Hickman tunnel catheter will increase. Coming to the last part, which is I think this is not the last one. Coming to the mediastinal drain. So what are the uses of mediastinal drain? Basically used to drain air, blood, fluid from the mediastinum. Commonly placed after the cardiac and thoracic surgeries, prevents complications such as pericardial tamponade or mediastinal collection. What is the course of the catheter? Usually inserted through subxiphoid or lower anterior chest wall through this approach. It passes anteriorly to the mediastinum, means the mediastinal drain should lie anterior to the heart and posterior to the sternum. Directed towards the pericardium or retrosternal space. What is the ideal tip positioning? The tip should lie in the anterior mediastinum, usually behind the sternum and anterior to the heart. The tip should, on the radiograph, the tip should project over the cardiac silhouette. Then side hole should be well within the mediastinal space, should not go into the pleural cavity. What if it is malposition? If it is too superficial or outside the mediastinum, then obviously there will be ineffective drainage. The fluid will keep accumulating into the anterior mediastinum or middle mediastinum, depending upon the surgery. If it is too deep, then there might be the tip of the mediastinal drain might irritate heart, that will cause arrhythmia, some heart injury, some wall injury might happen. If it is gone too much into the pleural cavity, consider on the right side or the left side, then there will be ineffective drainage of the mediastinal fluid. Okay, and if it is coiling, if the mediastinal drain gets coiled, or if there is any kinking, then there will be poor drainage. This is how the mediastinal drain will appear. This is the mediastinal drain. Okay, ideally the tip should project on the cardiac silhouette on the chest radiograph. Now this is the last drain that we'll be discussing today, and we have one more session after this. So what are the uses of mediastinal drain? Basically used to drain pericardial effusion or pericardial hemorrhage. Also in cases of pericardial tamponade, cardiac tamponade, also used post-operatively and post-procedure fluid drainages. What is the course of the catheter? Like the mediastinal drain, it is also put and inserted via subxiphoid approach, or sometimes might be through parasternal approach or apical approach from this side. It passes through the anterior chest wall into the pericardial space and courses along the pericardial sac. The tip of the catheter should lie within the pericardial space, in between the parietal pericardium and the visceral pericardium. This outer black line is the parietal pericardium and the inner black line is the visceral pericardium. This is where the tip should lie, in between the parietal and visceral pericardium. The tip should surround the heart. Then it lies along the cardiac border, commonly inferior or posterior pericardial sac. Then it should not project into the cardiac chambers or outside the pericardium. Okay, what if it is malposition? If it is inside the myocardium or cardiac chambers, then the risk of cardiac perforation increases. Trauma to the cardiac muscles, cardiac injury might happen. Patient might go on developing pericardial tamponade, hemopericardium. If it is outside the pericardial sac, then there will be ineffective drainage. The fluid or blood will keep accumulating within the pericardial cavity, and that will compress the heart, reduce the cardiac function. There will be ineffective drainage and possible pneumothorax. If it is kink or coiled, then there will be poor flow or no drainage. Okay, so we'll stop over here, guys. We have one more session to go. That will be the last session as far as the cardiovascular related adult lines and tubes are concerned. After that session, we'll be done with adults lines and tubes. Then we'll move on to pediatric related lines and tubes. Okay, so I'll be uploading this session on FRCR Shorts YouTube channel, and see you guys. Bye.